This is a laparoscopic bile duct exploration for intra and extra-hepatic lethiasis. Our patient is a 50-year-old male who is generally healthy except for active smoking, well known to our department from hospitalizations for symptomatic lethiasis and acute cholangitis. As part of treatment and investigation, he had undergone ERCP at least twice, with plastic stent insertion. He also undergone MRI MRCP in the US, which demonstrated extra and intrahepatic stone disease, with significant dilation of the biliary tree, with the CBD measuring up to 2 centimeters. After excluding a space-occupying process, a decision was made to proceed to exploration with performing a Roux-en-Y hepatic jejunostomy. Here we can see the preoperative MRCP that demonstrates an extremely dilated bile tree with extended intra and extrahepatic filling defects. We actually start the surgery with a gallbladder excision in a retrograde manner. Here we can see that there were no mentioned difficulties to manipulate it. A dissection within the peritoneum awaited complete mobilization of gallbladder. Then we insert a retractor in order to improve exposure in the area of the hepaticoduodenal ligament. During dissection, we noticed an enlarged lymph node in station 8A, and we perform its excision. Afterwards, we continue the dissection within the hepaticoduodenal ligament, using an urge source and blunt technique to mobilize the proper hepatic artery, with performing its isolation using a vessel loop. In a similar manner, we proceed to mobilize the CBD, and here we can notice the identification of the critical anatomical structures in the procedure, and also we can already notice the significant dilation of the CBD. After mobilizing the common bile duct, we proceed to transect it in a relatively high positioning, taking in consideration the aspects of bile duct blood supply, avoiding the middle least vascularized area. At this point, you can already see the trapped stones within the CBD. We extract the plastic stent from the distal bile duct that was inserted previously during ERCP. Then we proceed to perform an excision of the specimen with closing the stem of the distal bile duct using stapler. Afterwards, we proceed to the bile duct exploration, the part that is considered the most challenging in the context of laparoscopic surgery, starting with a combination of manual evacuation and irrigation of relatively large stones, as you can see. Then we perform a deep irrigation using a feeding tube and attempts of evacuation with Fogarty catheter. The last stage of exploration was to perform a cholangioscopy using a ureteroscope. Here you can already notice that there are still some stones trapped within the intrahepatic bile ducts. For the evacuation, we used the urological basket, as you can see. Finally, we proceed to the reconstruction stage. A Roux limb was transected with a distance of 50 centimeters from trites and was passed in a transmesocolic manner. In a laparoscopic approach, this stage is also considered challenging from ergonomic point of view, and it's important here to mention that it was performed by a highly qualified team with an experience of performing laparoscopic Whipple procedures. In view of the fact that the bile duct was significantly dilated, we decided to perform an end-to-side anastomosis using absorbable monofilament sutures. starting from posterior aspect, heading from 9 o'clock towards 3 o'clock. With adding a suture through the liver to release traction from the anastomosis area. At the end, an intra-enterostomy was performed without any mentioned difficulties. And a surgical drain was placed adjacent to the hepatic jejunostomy. The postoperative course was without any unusual events. A sample was collected from the drain on POD4, which was negative for bilirubin, and the patient was discharged on POD5. Pathology was benign with a component of chronic inflammation within the gallbladder.